I'm usually talking about things other than the science that I'm involved in when I speak on behalf of the kids. And so when the team said we want you to talk about the research that you've been doing over your career, I thought, well, that's a great opportunity for me to educate people, but also bring attention to a really, what I see obviously as an important problem, and one that has really driven my entire career in research, which is around a bug. And you'll see there the way I've called it, one of the deadliest bugs on the planet. And it is that, but it's also a bug that I suspect most of you have never heard of. Well, you probably have now that you've heard me speak about it, but it's not one that's well enough known. And I'm hoping that tonight will be the beginning of a bit of an education program. Very early on in 1993, we noticed that there were a whole lot of children presenting incredibly unwell, who all had some very similar things in common. They had started with a sore throat, and then within hours, they looked like this. They were turning up on death's door at the children's hospital. They had flushed red skin, they were pale, they were in shock. And then a short time later, like that child, they were in intensive care with tubes coming out of every orifice and every possible place on their body. They were receiving all sorts of intensive therapies. Most of them survived, thanks to the fact that they were in one of the best children's hospitals in the world. Some of them died, some of them lost limbs. It was a devastating series of events, and it was a series of events like we hadn't seen before, at least in recent times. And of course, most of you would be thinking of bugs that we hear about in the news, meningococcus or golden staph. Well, the other thing they all had in common was that the bug was not those. It was a bug called Streptococcus, Group A Streptococcus. Strep A is what we like to refer to it as. And it's a bug that has since been my life's work in my research. And indeed, at that time, I started my science. I started looking at the bugs that were causing these kids to be very sick, and I realized that the bug was mutating. It was going through sorts of changes. And in fact, we weren't alone, that there were lots of cases like this happening around the country and around the world. Fast forward 30 years approximately, and it still hasn't gone away. And you'll all be familiar with this face. That's Aishwarya. Aishwarya, you all know, died of sepsis at Perth Children's Hospital. What you may not know is that she died of sepsis due to Strep A. Do you think this is new? It's not new. If you go back to, this is a quote from the 1700s, no one could do an act more beneficial to society or glorious to himself than by teaching humanity how to inoculate this fatal disease. Scarlet fever exists with all the degrees of virulence from a flea bite to the plague. Scarlet fever is caused by Strep A. Toxic shock syndrome, like I showed you, is just a really severe form of scarlet fever. And so this is a disease that's been around from time immemorial, and we need to do something about it. And I'm hoping to tell you that we are very much on the trajectory to answer Erasmus Darwin's request. So occasionally this makes the headlines, and we do sort of see it appear, but we need more people to know about Strep A and what to do about it. Most of you will know about meningococcal disease, and the great thing is that over time we have seen meningococcal disease gradually become less common. It's still around because we don't vaccinate against every one of the strains, but vaccines have made a difference. But even before we had vaccines, we had a situation where Strep A, invasive Strep A, nasty Strep A, was more common and remains more common than meningococcal disease ever was. Strep A goes through surges like meningococcal disease did, and it causes just as much fatality, just as much devastation. In Australia, we have seen, ever since we've started keeping records, persistent invasive, nasty Strep A infections. And in recent years, you'll see on the right, we've seen surges. We've seen cases like the cases I presented to you coming time and time again to Perth Children's Hospital. More and more families devastated, more and more children's lives affected forever, sometimes taken from them. So what can we do? Well, I will be telling you during the course of this lecture that for most Strep A diseases, there is no magic bullet. For invasive Strep A diseases, there is a magic bullet, and that would be a vaccine. How do I know that? Vaccines work. I've put on there the slide 3 diseases that are caused by bacterial infections. Haemophilus, or Hib, on the top left, pneumococcus on the top right, meningococcus in the middle. All cause similar sort of syndromes to Strep A, kids getting really sick really quickly and dying. What I've also shown you there is that the green arrows is when we introduce vaccines, and we see these nasty infections disappear. I'm very fortunate. I have seen the disappearance of a disease, Hib. When I was a trainee doctor, Haemophilus influenzae was one of those things you really feared the most as you went to the emergency department. If a child came in with it, it was really difficult to know what to do with them. Medical students these days never see a case, thanks to vaccines. So if we can get a vaccine for Strep A, we can get rid of nasty, invasive Strep A infections. So why don't we have one? Well, people have been working at them for decades, many, many decades. But we've never had one taken from development right through to licensure. Why? Well, there's a whole lot of reasons for them. I've listed a few on this slide, where there have been questions around, can we do it? Are there technical issues to do with the bug that make it not possible to develop a vaccine? Do we have enough compelling data on the fact that it's a big deal and we need a vaccine? And most importantly, are we convinced that there are commercial drivers? Because the reality is that vaccines are normally developed by big pharma. Industry takes a vaccine, they develop it, they invest often up to $1 billion or more to develop a vaccine, knowing that there will be a commercial return. And we see the benefits as well in terms of health. But we have never had a large pharmaceutical company take a vaccine all the way through. Why? Because of all these risks. Basically, what they tell us is that they are not willing to make that early investment with the lack of certainty that they can overcome all those barriers. Well, a few years ago, the international Strep A community, the research community, the public health community got together and started dissecting what the barriers have been to a Strep A vaccine. And we actually think every single one of them is able to be circumvented, that we can develop a vaccine. We have compelling data, and there is a commercial driver. And what we did was recognize that we needed to de-risk that early stage of development. We needed to not rely on pharmaceutical companies taking the lead, but the public sector, the academic sector, could come in and demonstrate that we can take a vaccine to a trial to show that it's safe and that it works, and that will be a critical step in terms of engaging the rest of the sector. We went to the Australian government. They gave us $35 million. We've supplemented that with some more philanthropic money, and thus ASAVI was born, the Australian Strep A Vaccine Initiative. That is headquartered at the KIDS. It's a partnership with the Murdoch Children's Research Institute in Melbourne, and it's one of the things we are very proud of. And Alma Fulleria, who's in the audience, is the lead of this program. What are we doing? We're taking the risk out of that early stage clinical development. We are looking at vaccine candidates developed all around the world and saying we want to pick the best and we want to take them through clinical trials. And what's really unique is that we don't have our own vaccine. We are looking at developing our own vaccine. That's another part of our program. But for now, we want to accelerate the vaccines that are out there. And there's no one else in the world has done this for vaccine development. And we are making great progress. So there are 3 vaccines that we are working with, and we will be starting clinical trials in Australia in 2025 on these vaccines. We have set the ground for then taking those vaccines into the trials to show that they work by checking kids in Perth, Melbourne and Adelaide to see whether or not they've got strep throat and developing that as clinical trial sites. We've worked up a laboratory assay that is internationally approved and is of international standard. Very importantly, we have a First Nations population that needs this vaccine, and I'll talk a bit about that during the rest of this talk, that we have engaged with and will continue to engage with First Nations communities to ensure that Aboriginal kids are among the first in the world to benefit from a safe and effective Strep A vaccine. And we're trying to raise awareness. We need people to know that this is a disease that we need a vaccine for. And as a result, we're connected globally around this. Just to let you know that one of the findings we have is that there is still a lot of strep throat out there. If anyone thinks it's disappearing, it's not. We found that in 476 kids, there were 377 sore throats in just 12 months. So almost every kid gets one every year. 25% of those are due to Strep A. This bug is out there, and those sore throats can then lead to a whole lot of complications. So the vaccine program, I just wanted to highlight as a major piece of work that I often talk about the light at the end of the tunnel that seems to be disappearing. For vaccines, it's coming closer. I do believe we are on track for a vaccine, but it's still going to be a few years away. And this is actually the original data that I presented and published. What I found was that rheumatic fever was occurring at rates in the Aboriginal kids of the Northern Territory well in excess of any that had been described anywhere in the world. And it got a bit of attention in the papers. It certainly raised awareness amongst the medical groups. What I also discovered was that there were other Strep A diseases, including those nasty strep infections. So the Aboriginal population of the Northern Territory was not only having to deal with rheumatic heart disease, a disease that the rest of the country didn't have to deal with, it was also having to deal with all those other Strep A diseases at much higher rates. So I better tell you about this bug. Strep A, that's what it looks like under the microscope, that's what it looks like on an agar plate when we grow it. And it has the unfortunate fame amongst bacteria as causing the broadest range of clinical infections of any bacterium. So everything from those very mild infections that I've talked about, sore throats, skin sores, to then complications. And those complications on the left can be that the blood poisoning, can be the severe infections, flesh-eating bacteria. Yes, that is largely caused by Strep A. In the middle, it then can do something weird, which is releasing toxins, and that causes scarlet fever and toxic shock syndrome. And then on the right is where it really gets interesting, because it has the ability to induce an immune reaction in the body when you get infected that then attacks your own body, autoimmune disease. That's rheumatic fever and rheumatic heart disease. An incredibly broad spectrum of disease, which is one of the challenges we have in trying to gain attention for this bug. Because are we talking about Strep A? Are we talking about sore throat, toxic shock syndrome, rheumatic heart disease? We're trying to package all of this up. What I can tell you is that it's a big deal. Every year there are 616 million Strep A sore throats. There are 55 million people currently living with rheumatic heart disease around the world. That's immense. More than 500,000 deaths. These are conservative figures. We are very confident of this. More than 500,000 deaths a year due to Strep A. More than 15 million cases of that severe infection I talked to you about. And yes, scarlet fever has not gone away. It's still there, and indeed it's had a resurgence in the recent years. And so if you were to do a league table of the most lethal bugs on the planet, Strep A comes in at number 5. These are 2019 data. Since 2019, of course, there's another bug that's appeared, COVID, so that's why it's gone from 4th to 5th. But it's a pretty amazing list when you look at it. So look at all those other infections. You will have heard of most of them. You will also be aware that most of them either have vaccines or they have massive efforts that are going in to develop those vaccines. Strep A is the outlier. It has very little investment, and that's why advocacy for us is just as important as science. Again, like the nasty scarlet fever and strep sepsis I talked to you about, it's not as though rheumatic fever is anything new. Indeed, it's not that long ago, it was a problem for everyone in this country. This is a clip from the Sydney Morning Herald in 1949. We have good data that says that in Sydney and Melbourne, in the 1940s and 1950s, the rates of rheumatic fever in the non-Indigenous population were the same as we see in the Indigenous population of Northern Australia right now. So it was a very common disease back then. Why has it disappeared from the non-Indigenous population? Because of economic development, because of living conditions. It's not particularly because of susceptibility. And we do know that we need people to be aware of this. Every one of you will have someone in your family, a great aunt, a grandmother, who had rheumatic fever as a kid. Kevin Rudd walks around with an artificial heart valve because he had rheumatic fever in the 1960s in Brisbane. It's not that long ago. Yet it's a disease that's out of people's attention because it's restricted largely to the First Nations population. So what is rheumatic heart disease? Well, you get the strep, you get exposed to it, you get a strep infection of your throat or your skin, and then a few weeks later, in some people, this immune reaction causes you to be sick. Swollen joints, fever, maybe some unusual movements. That's acute rheumatic fever. You get quite sick, you have to go to hospital. Almost all of that gets better. But the other part of your body that can be affected is your heart valve. And you get damage to the heart valve, and if you get a bad episode of rheumatic fever, or every time you get a strep infection again, you can get rheumatic fever again, that makes more damage to your heart valves. Your heart valves, which are supposed to let the blood only go one direction, leak, and the blood comes back again. Puts excessive pressure and strain on the heart. That causes heart failure. And the complications can be devastating. Stroke, infections, and obviously just having heart failure, and that can lead to early death. That's the disease we're really trying to prevent. Nasty strep infections are a huge issue. Rheumatic heart disease is an even bigger issue globally. How big a deal is it in Australia? Well, this is the global burden of disease, a big exercise around the world. And what you can see there is colours. So the more towards red you get, the higher your burden of rheumatic heart disease. And so you'll see Australia looks pretty good. We're like the United States and Canada. We've got very low rates of rheumatic heart disease. Of course, that hides the reality. So in our country, you will see that in the top right is the non-Indigenous population. It's all blue. It's all low rates. In the bottom right is the Indigenous population, and it's red. And it's red in the north, which is where the highest rates are, but it's still a problem in the southern parts of Western Australia, South Australia, Queensland, even in New South Wales. So this is a disease that is a massive issue around this country. So in Australia, more than 10,000 people have rheumatic heart disease, Aboriginal people. We know that if we do nothing different, almost 10,000 cases, new cases will occur by 2031, and that will lead to many people with very severe disease, needing surgery, and many people dying. And this is a problem that's essentially restricted to First Nations people. So this is some data that shows you the types of diseases that contribute to the gap that we're trying to close, and how much more common in Indigenous people they are than non-Indigenous people. And so if you look down that list, things like youth suicide, 3 times more common. That's just awful. The smoking rates, the diabetes rates. Look at the top. That's not 5.5, that's 55 times. Rheumatic heart disease, a young person dying from rheumatic heart disease occurs 55 times more commonly in Indigenous young people than in non-Indigenous young people. This is emblematic of the gap that we're trying to close. And it's because of living conditions of social injustice. And so what can we do? Well, there's things we can do every step of the way. I talked to you from getting exposed to strep right through to getting rheumatic fever, rheumatic heart disease, and then obviously trying to prevent you dying. There's things we can do at every step along the way. We can try and improve housing and reduce the exposure to the strep. We can have treatment of sore throats and skin sores. We can, obviously, when you develop rheumatic heart disease, make sure you get good medical and surgical care, and that's really critical. It also chews up 99% of every dollar that's spent in any country in the world on rheumatic heart disease. You can't not do it, but it does nothing about stopping the flow of new cases. What's the most effective one? It's this thing called secondary prevention. What do we mean by secondary prevention? This is injections of penicillin. Penicillin is incredibly effective for strep. And when someone gets rheumatic fever, we give them a penicillin injection with a needle that looks like that in their thigh or in their buttocks every 4 weeks, usually for a minimum of 10 years. Now, that works. If you get those injections, it works very well. It stops you getting further strep infections. It stops you getting rheumatic fever. It can be life-saving. But it's a big ask, especially for kids, to get painful injections every 4 weeks. So we need to ensure that we can do that, but we need to do better, and I'll get onto that in a second. All right, let me quickly take you through what we've been doing. And I've tried in one slide to summarize 30 years of research translated, so I'm not going to touch on the vast majority of things we've done, but there are some things that research has definitely contributed to about how we're battling rheumatic heart disease. Register-based control programs. When we started our research, there was no such thing. The government authorities, the health departments, didn't really have a coordinated approach to rheumatic heart disease control. And so when I presented my data in 1997 in the Northern Territory, the next day I was on a plane with the head of the Centre for Disease Control in the Northern Territory to Canberra. And we managed to convince them that we needed to establish a register in the Northern Territory in the top end and to start a control program. And that was the first one. We now have control programs in every jurisdiction that has high rates of rheumatic heart disease, including in Western Australia, focused on making sure we know who's got it, making sure they get access to good care, and including trying to improve those delivery of those penicillin injections. And there's been significant success for those. That came straight out of the research. National guidelines. We realised that we needed to have some agreed guidance that we could give the clinicians, Aboriginal health workers, doctors, nurses, about how to manage rheumatic fever, rheumatic heart disease. And so back in 2006, on the right there, the top, we published the first Australian guideline. They've been updated 3 times so far. The 4th edition is about to come out. And they are, without doubt, the international gold standard for what the evidence shows about how to manage rheumatic fever, rheumatic heart disease. Again, that was driven by research and researchers. And then the other thing I'll point out is the diagnosis of acute rheumatic fever. It's a really tough disease to diagnose. We don't have a diagnostic test. I'll get onto that in a little while. But what we do know is that the diagnostic criteria that were used since 1944, called the Jones criteria, they had become increasingly irrelevant for a population like the Aboriginal population that had a high rate of disease. I won't go through the details. What I will say is that in Australia, we developed our own adapted set of the diagnostic criteria that were much more applicable to the populations we were dealing with. In 2015, the American Heart Association, for the first time ever, invited foreigners onto their committee, and they essentially adapted the Australian criteria. So the Australian criteria are now the basis on which the international Jones criteria are based. All of that arose because of the research we did that documented all the reasons why the Jones criteria were no longer relevant. So there's a lot more that's happened over those 30 years that research has contributed to. But I guess I want to get to this question, which is a few years ago, we also started asking, why don't we have a comprehensive approach to this disease in this country? Why aren't we talking about eliminating rheumatic heart disease? Because if there's one country in the world that should be able to eliminate this disease, it's this one. We've got the resources, we've got the focus on closing the gap. And so when I say we, it's we as the research community at the Kids, connecting to a range of other research organisations around the country that we collaborated with, got some funding, and we spent the next 5 years developing that plan. A plan that could be implemented within the current policy settings to actually get rid of this disease. And during the course of that, we also had our kind of eureka moment, which is just kind of stupid, but the eureka moment was we finally listened to what the Aboriginal stakeholders have been telling us for 30 years. And they said, you've got to have Aboriginal voices at the heart of it. And we brought those Aboriginal voices in as the End Rheumatic Heart Disease Alliance. We had all the Aboriginal community-controlled organisations involved, and they very much guided these guidelines. And so in 2020, we released the Endgame strategy, which is a blueprint to eliminate rheumatic heart disease in this country. And we had key elements that included Aboriginal leadership, included empowering communities, and very much in response to that Aboriginal leadership who kept telling us, stop focusing on just medical solutions if you keep telling us this is a disease of the social determinants. We put the social determinants front and centre. Environmental health, housing are absolutely critical and essential elements if we're going to control this disease. The great thing from a researcher's perspective is that we released these these guidelines. They were launched by the Health Minister and by Pat Turner, the CEO of the National Aboriginal Community Controlled Health Organisations. They now, those two, the government and NACCHO, now run the National Rheumatic Fever Strategy, and the endgame strategy is a guiding document for that strategy. So that's fantastic to see this being put into practice. Of course, they haven't yet got the resources we need to actually implement it all, but we are heading in that right direction. And that goes to tell you what we need to do as researchers when we're dealing with First Nations issues, and I'll come back to that. So what have we done at the kids? And I really want to finish with this kind of summary of how we've tried to tackle the problem. Because I said before, other than a vaccine for invasive strep, we know a vaccine is going to be incredibly important for all the other strep diseases, but it won't be the same magic bullet. There are a whole lot of reasons why, but we know that getting access to vaccines in the low middle-income countries is not so straightforward. We know that there are a whole lot of other aspects that need to be dealt with, including the root causes and including the skin infections and looking at whether or not we can get better therapeutics. And so we have 5 teams working together to try and tackle every part of the puzzle. And what we've also done is put at front and centre in the middle Indigenous governance and Indigenous leadership. That's because we recognise we have to be true to what we say we need to do, and that's where the kids has an overarching commitment to doing things properly in First Nations health. So I'm going to spend a couple of minutes whipping through just a few highlights of some of the things we're doing. So for example, under Asher Bowen's leadership, we have a healthy skin program. They're really tackling those skin sores and scabies that I talked to you about that are rife in many communities. And they've done a very well-designed community trial in the Kimberley that has just reported its results very recently. And they found the 50% reduction in the rates of skin sores at the end of the trial. That's an incredible impact. And they did it through a combination of different approaches, both the medical approaches to making sure that skin infections were diagnosed and treated, scabies was diagnosed and treated, but also that prevent aspect, which was very much driven by the community, focusing on what families could do in their physical environment to try and prevent these infections. They developed resources in local languages that are now being used in those communities to understand the importance of skin infections. And of course, we've also led the development of the National Healthy Skin Guidelines, which really are a bit like the rheumatic fever guidelines, the Bible that clinicians use. So a wonderful example of practical science, high quality science, to give us guidance about how to control skin infections. What about that penicillin? What can we do to not only encourage and improve the ability for services to deliver penicillin, but can we come up with something better? And every time I go to a conference, everyone asks me, why can't we come up with something better than this big, bloody, painful injection? Well, we can, and we are. We have done some research that demonstrates that just with the existing formulation of penicillin, which we currently give into your muscle, and you sometimes can't walk for days, then in fact it's much more effective if you give it under the skin, and that allows you to give much bigger doses, and lo and behold, we've also discovered that it hurts a lot less. And we have a program that we think within 1 to 2 years should be able to be rolled out across the country and indeed across the world, where people, instead of every 4 weeks, will come in every 2 to 3 months and have what is essentially a painless or a very, very low pain infusion of this penicillin under their skin. That is going to be an absolute game changer. But we're also coming up with a better formulation. And so right now, we have 4 novel formulations that are being developed that are in the pipeline for testing. And we are hoping eventually to even see that this could be an Australian manufactured product, not just for Australia, but for the world. And we are very confident that we will be able to develop much better, much more effective penicillins. And that alone will be a dramatic advance for controlling rheumatic fever. We have a team focused just on the strep, understanding its biology and how it targets the tonsils. That's a picture of strep infecting a tonsil cell, how it triggers rheumatic fever, and a whole lot of aspects there, but one thing I do want to focus on is that diagnosis of acute rheumatic fever. I mentioned before that it's very imperfect. Yes, we're trying to improve the clinical diagnostic tool, but it's still a blunt instrument. We still often end up not really sure if we are saying that child has rheumatic fever definitely. If we get it wrong, if they don't have rheumatic fever, then we're condemning them to 10 years of painful penicillin injections, plus also not diagnosing whatever they do have. Or if we miss the diagnosis, that can have devastating consequences because they don't get their penicillin, they can get rheumatic fever and they can die. And what we've done is brought the latest science to this. And we have looked at the sequencing revolution that's occurred in the last 10 to 15 years, enrolling kids initially in Uganda, then in Darwin and Auckland, and now globally, who have rheumatic fever, or kids who have other infections that could be rheumatic fever, or kids who have other infections that aren't rheumatic fever. And we're just basically testing every single chemical, every single immune marker we can, and looking to see whether or not we can come up with some what we call biomarkers, the diagnostic tests for rheumatic fever. What I can tell you is we absolutely can do this. So we've got some early biomarkers that look like they are almost perfect in diagnosing rheumatic fever. I am confident in 5 years' time we will have on the market, hopefully essentially for low-income countries, a diagnostic test for rheumatic fever, so that kids who present, that the clinicians can be confident that yes, that's what they have. A lot more science is occurring in the kids. What we do also have is recognise that we are part of a global community, and we have connections all over the world for the science we do. A lot of work that's happening in Africa, some really important work that's happening in the Pacific, and of course our collaborations in other countries. And one example is this thing called the Strep A Vaccine Global Consortium. This is, in addition to what I talked to you about before, ASAVI, the Australian Strep A Vaccine Initiative, which is very much a doing organisation, testing vaccines ourselves. We're also connected to this, and we're part of the founding of a global consortium that's raising awareness and trying to connect industry, trying to connect policymakers into this world, and doing the health economics. And we've done some fantastic modelling, and our team, together with a group from Harvard University, have produced some incredible data. I've got one graph there that shows that if we invest in a Strep A vaccine over a period from 2022 to 2051, the savings would be $4 trillion. And we've got investment cases for individual companies, investment cases for governments, trying to make the case that it's not just common sense, it's not just good for the health of people, saving lives, there's also a commercial driver, there's an economic argument here. We would not be anywhere without recognising that all of this work can happen in a lab, can happen in the field, but if it's targeting an issue in this country that is predominantly a First Nations issue, then someone like me has only a certain level of chance to make things happen. If we take the next step and say we need Aboriginal health in Aboriginal hands, and that includes Aboriginal health research, then we start to see dramatic changes. And I've got just a sample of 4 of the leaders who've been incredibly influential in the work I've presented tonight. Pat Turner, the Chief Executive Officer of NACCHO, who's been an absolute champion for the work we've done, including our vaccine work. Vicky O'Donnell, here in Western Australia, similarly a champion for our work. On the right, 2 of our people at the Kids, Professor Alex Brown, a long-term colleague, one of the best Aboriginal health researchers in the country, and has also been incredibly influential in the rheumatic heart disease work. But I particularly want to pay my respects to Associate Professor Glenn Pearson. Glenn is our Director of First Nations Strategy and Leadership. He's also very much involved in our research, and as of last year, became the head of our NRHD program. So he now leads that program, and what we've also got under his leadership is an absolute commitment to the work we do at the Kids, but also through our national connections, being guided by appropriate Indigenous governance, including people with lived experience of rheumatic heart disease. And that gives me confidence that we're in the right hands. What I presented to you tonight is the work of many, many people. This is the END-RHD program. This is our researchers at the kids. You can't see them because they're all so small because there's so many of them. It's incredible. When I started at the kids 12 and a half years ago, there were a couple of us working on strep and rheumatic fever and rheumatic heart disease. We now have 55 team members, 15 students, 13 honorees just at the kids, which is quite a team, and they are the best, the most dedicated team members you can imagine. And of course, we wouldn't get anywhere without all those connections. And again, I've deliberately tried not to put logos on there because there are so many organisations around Australia and around the world who've been part of this. I feel like in the 12 years since I've arrived at the kids, we've gone from being a kind of a niche program to finally getting somewhere, getting attention. What we now need to do is to take the next step and take it beyond the research into the hands of the community. So what do I want you to take away today? Well, remember Strep A. When someone talks to you about nasty infections, think Strep A. When you've got a kid who's sick, think about Strep A. It's the nastiest bug you've never heard of. We need people to be aware of it. That for a vaccine is going to be an incredibly important advance, but we also need to be taking a holistic approach, a multifactorial approach to tackling these diseases. And we are seeing a lot of advances. We've got some really exciting stuff that's already happened, and we've got some more things in the pipeline. And stay tuned, we'll be telling you a lot more about them. And hopefully you'll leave here with a bit of pride, because a lot of what's happening in this country and around the world is being led out of Western Australia and out of the kids. And that's thanks to the First Nations leadership and governance that we have. And I'm very proud to say that as a researcher who's been working for 30 years in this area, I now cast myself as a partner and an ally rather than the leader of this area. And that's as it should be. Thank you very much.